And good evening, everyone. How are you? And welcome back to PerfWeb. I'm, of course, your host, Joe Basha. First, I want to thank all of you for your continued support in helping to make PerfWeb your #1 perfusion education hub. We would also like to remind all of you that our webinars are approved for ABCP Category 1 CEUs. Please refer to our website, perfweb.us, for a complete list of ABCP-approved webinars, for webinar registration, and for the amount of Category 1 CEUs that will be awarded. As you know, our programs are free for everyone to watch, so we really want you to participate. You only pay if you need the CEU certificates. We want your participation and for all of us to learn together. Also, please give us a few days. We're going to email you a SurveyMonkey evaluation that has to be completed. When it gets completed, we know it immediately, and then your certificate will be sent to you via email to the email address that you registered for the program with. Okay, now, click the red subscribe button right here and become a part of our PerfWeb family, right there. Next, click the bell icon that's right over there next to it so that you'll receive notifications if we put a program on and you didn't know about it. You'll see that the New Orleans conference, or PerfWeb is in fact live. Okay, I'm a little bit confused about where I am here, so I apologize for that. But we're constantly working to improve the end user experience. For those colleagues that cannot make it to a meeting, if you can't take a Wednesday, Thursday, Friday, or Thursday, Friday, Saturday, and go to a live meeting on site, how are you going to take, because you're not staffing, you don't have coverage, how are you going to take the Wednesday, Thursday, Friday off and watch a program from your computer? You're going to be in the operating room because you don't have coverage. So our goal here is to develop programs that are done in the evening after general hours. I understand there's call, in some cases go late, but we try to do them in the evenings and also on weekends so that we can best accommodate your all schedule. And look, if you do the evaluation and send it in, or just drop me an email or give me a call, whatever you want to do, it would be real helpful for me to understand what works best for you. We're trying to find the right formula, and we're looking at the next series that I'm going to put up. We're going to try something a little different because we're just trying to find the right blend and mix that's going to work best for you. And of course, you should have received our flyer, which should be coming up right now for you, in the mail from the ABCP. We mailed one of those flyers to everyone. So please keep that website in mind. Look on there, and also get the notifications on YouTube. I think will be very helpful. But our goal is that you can get all of your Category 1 CEUs right here from us. As of now, we have 2 ways for you to participate and to interact with us. The first way is the YouTube chat feature, okay? The YouTube chat feature, here's an example of it here, is right there. It's very easy to use. You do have to have a Gmail email account, and you cannot be in full screen mode in order to use the chat feature. But I will be monitoring all of this during the presentations and discussions, and if you put up a good question, it will be very helpful to us, and we can get you to participate. But I think the better way, what I prefer, is for you to use the telephone. We have a dedicated phone number, and here it is here. We're going to throw it up, and you can use that in which to call in, be live on the air, give your point, ask a question, be part of the discussion, whatever the case may be. However, either way, chat or telephone, please tell us your name, where you work, what you do. And again, there's the number right there that you can call in with. So with all of that said, welcome to the program this afternoon. I really appreciate you being here and taking your time to do this with us. And we're going to go ahead and just jump right into everything going on. So let's start with, as you may be able to tell, I think it's possible for you to tell, Dr. Badia, who should be sitting right here, is in fact not sitting right here. Now, why is that? Well, I have to tell you, Dr. Badia is a really good guy, and he truly did have a legitimate emergency. He called, has apologized vehemently, said he would make it up to us, and we are going to reschedule his talk. This is approved for level 1 CEUs, the program. I am going to give a presentation, so don't fret that you're here and not going to get credit for today, because you will. And then when we reschedule Dr. Badia, either at the end of this month or beginning of next month, that program will in fact be free to you. However, and with that said, let me... Indeed, the show must go on. So, to sort of give you some idea of Dr. Badia, so you will want to come back, I wanted to show you a couple of things. The first thing is, Dr. Badia was actually a child actor and of a very popular program. I used to love Lily. I loved Lily. And she was the weird one on the show. Here he comes.
Boy, look at the neat lightning. I sure hope it hits our house.
Eddie, how do you like me as Priscilla?
Corny. Why don't you dress up as Lady Gorilla or something pretty like that?
The similarity, there is no denying that Dr. Badia is Eddie Munster. No denying it whatsoever. Now, with that said, in the spirit of forgiveness, as only a perfusionist can give to a heart surgeon who is not here to do their webinar and making me have to scramble, Dr. Badia is an off-pump cabbage advocate. Now, you all know, if you know me at all, you know that I think off-pump cabbage is just the worst thing anyone can do, except under extraordinarily unique circumstances. I do think it has a place, but they're very, very, very specific, very few indeed. And I'm not the only one. Even Dr. Ochsner, Dr. John Ochsner, seen here trying to explain to Dr. Badia why doing off-pump surgery is misguided. But yeah, he still doesn't listen, not even to Dr. John. In addition to that, Dr. Badia happens to be quite the man around town, and he is a wine connoisseur. And not only that, but this is a picture of him on a published wine magazine, standing outside his own wine cellar at his home. And indeed, at the New Orleans conference coming up, he is going to give a talk on the history of wine and its medicinal properties. I think it's going to be a really, really, really good talk, because even though he's an okay heart surgeon because he does his cases off pump, he really does know his wine. There is no question. He also has gone around with people like Lady Gaga. Now, I have to say, that's pretty impressive. I wouldn't mind having had the opportunity to hang out with Lady Gaga for the evening. That seems like it'd be pretty much fun. But this is Dr. Badia. He's an elegant young man with his beautiful wife. I don't think there's any question that, that Dr. Badia was the reacher, and that his beautiful wife Gina was the settler. Now, with all of that said, it's only fair to tell you that Dr. Badia, he knows how, he knows that I have revealed to you all that he is in fact Eddie Munster. But he has sent me a text, apparently believing that this is what I look like. Is there a similarity? I'd like to know what your opinion about that is. Now, with that said, I am going to be giving us a talk on the advancements in specifically extracorporeal technologies and the future of perfusion. Of course, you know, I've been a perfusionist for 39 years, and I thought that was a long time. But I recently spoke to Ed Evans. I didn't realize he was on his 50th year. And I also spoke to a young lady, I believe her name was Marilyn, I believe. It might have been Mary Ann. I don't remember. I'm going to have to go back and look. I'm blanking on your name if you're watching. I'm sorry. But she's 42 years of practicing in this profession. That is a wealth of experience. And look, I am a big believer in two things. One, I think you can learn a lot in perfusion school, and we're going to do some discussions someday about, you know, how training has changed, not just for us, but for surgeons and for everybody else in this profession. But also, so I don't think you could learn a lot, but I don't think you can ever really teach experience. That just comes from time. And it's going to be really hard, I think, when this profession loses some of these folks that have been in it for as long as they have, because the lessons that they've learned are just really incredible, and they're going to get lost. Hopefully they'll want to participate in stuff like this so they can continue to teach. In addition, I think to know where you're going, you need to know from where you came. I think that's really very important. And I am going to have a panel, so I have both, I have Patrick O'Toole and Rodell Ebus, who are going to both join me up here at the desk, at the anchor desk, and be a part of the discussion after my presentation. Listen, we're going to open the phone lines early. We want you to call in. We want you to, again, use the YouTube chat tool. We're streaming both to YouTube and Facebook. But let me go ahead and get this presentation done and out of the way so that we can talk about some of these things. Is everything okay? Okay, good. All right, so let us begin. Now, in the upper left-hand corner here, let me see. Oh, I have to look down there. Upper left-hand corner, this is Dr. Forrest Dodrell. Dr. Forrest Dodrell was up at Wayne State. This was taken in the early 50s, probably about 1950. This fella here is an engineer with General Motors, and if you look at this pump, this is a heart pump only, a circulatory device, not an oxygenator, but it looks a lot like a straight six General Motors engine. Once again, General Motors engineers. They were very involved in the development of the heart-lung machine in the early days. In addition, in fact, General Motors said, we pump gas, we pump oil, makes sense we should pump blood. That is truly something that they said. Now this fellow here, Calvin Hughes was a biologist with General Motors, a research biologist, and they actually put him in charge of this heart-lung machine project, if you will. He did the first case, so I think he may in fact be the first true perfusionist, because this predates the Gibbon pump and the first successful use of the heart-lung machine. But he went to medical school. Everybody was sure he was going to be a heart surgeon, and what he decided to do was become a psychiatrist, probably because he was a perfusionist, and we all know what this profession does to us. Now, this fellow over here, Dr. Mustard of the Mustard procedure, there's actually a Mustard procedure, of course, for congenital anomaly, and there's also a Mustard procedure for an orthopedic procedure. So he's I think he's the only surgeon that's had a procedure named for him in two completely different disciplines of surgery or medicine. But his idea was to put monkey lungs inside this flask that you see here, pump the blood through the monkey lungs, and then oxygenate it, and then pump it back into the patient. A pretty interesting idea. And then you got this guy here, Dr. Walt Lillehei. Now, Dr. Walt Lillehei looks like the most intimidating most intense individual with the biggest headlight that could do nothing but create pain. But he was actually known as just a really, really funny guy and just a really good guy to be around. And a friend of mine, Steve Igo, there was a book about him, and he was telling me some stories that I find fascinating. I need to get the name of that book again and read it myself, but he was telling me that he got into tax trouble. He sort of got excommunicated from a lot of organizations and societies because of that, and sort of was like drifted off, and then came back, and I think it was St. Jude Medical is what he started, and did very, very well. But he advocated for cross circulation. Of course, cross circulation takes the venous blood from the baby, pumps it into the venous side of the parent, and then takes the arterial side of the parent and pumps it into the baby, so that there's a euvolemic state on both sides. And they've done it. They did it. It worked. Okay, it worked. But I'll see, I have to click both of these.
Dr. William Mustard's lifetime of surgical innovations began in 1944 while serving in the Canadian Army Medical Corps, where he used a prosthetic glass tube in a wounded artery to save a soldier's leg. Back in Toronto after the war, he continued to build a reputation as one of Canada's great surgical pioneers.
Dr. Mustard was a remarkable man because in that era, which was over 40 years ago now, he was able to practice in two specialties, orthopedic surgery and cardiac surgery, because both of those fields were just getting developed at the Hospital for Sick Children at that time.
He cared about children so much, and they loved him. They just felt so at home with him, with his sense of fun. And he was a small man physically, and they didn't feel like a giant was handling them when he was dealing with them. But, so he really enjoyed with the orthopedics. There were things he could really do. He could help these kids, particularly in the polio years. He had so many then that wouldn't have been walking without his operations, and he loved that he could give them a normal childhood.
He developed an operation on the muscles around the hip joint in poliomyelitis, an operation that was very effective. So that was known as the Mustard operation in orthopedics.
As far as I know, he's the only doctor worldwide that's had two totally separate procedures named after him, the Mustard procedure, one in the field of heart surgery and one in orthopedics, and that's really unusual.
As a cardiac surgeon, Dr. Mustard devised an operation to correct an inborn defect in blue babies.
The problem the children had that his surgery corrected was that instead of the blood circulating through the body in a figure 8, it went around like in two circles, so that the blood was just kept going around to the lungs and getting oxygenated, but the blood going to the body wasn't picking up oxygen, so it was blue, and that's why they called them blue babies. Instead of trying to correct the heart back to normal, his operation made the heart sort of work backwards. Instead of the left ventricle being the main pumping chain, the right ventricle was. But in children that didn't matter because they hadn't yet developed the large ventricle that an adult would have on the left side from all the pumping over the years, and the right side could do it. But it was an intriguing, ingenious kind of solution. Others everywhere had been trying to put the vessels back in their proper places, and it couldn't be done. So he had, an insightful way of fixing this problem.
He had a great deal of insight. He had a very inquiring mind. He did good basic research. He was a superb technical surgeon, very wonderful surgeon to watch work. It was just like watching ballet. I mean, to see him operating, it was just marvelous. And he was a very innovative investigator, that is, a researcher, a stimulating teacher.
He didn't like pomposity or stuffiness or conceit in anybody, and particularly not in doctors. He thought it was too often that they seemed to think they were demigods or something that were just above everybody else. And he had wonderful ways of knocking this stuffiness out of people. Teaching his students, just in the middle of a lecture, he might stand on his head, just to, as he said, get their attention, lighten things up a bit. His father had a deep philosophy that Bill held tightly to was that it's not what you get, it's what you give to your community that makes you rich.
That's very nice. That's very nice. That was a lot of good information about something. And up in Toronto, okay? So, you know, that's Canadian medicine, right? We've discussed that many, many times. Now, let me show you that right-sided heart pump. Or heart, but not right-sided heart pump. Just isolated heart pump is what I meant to say. And that's pretty intriguing too. But look, whether you're talking about cross circulation, whether you're talking about monkey lungs in a flask, whether you're talking about this pump that you're looking at here that looks more like a straight six car motor, whatever. If somebody had walked in the pump room, if Dr. Mustard walked in the pump room today and said, Joe, I think, or Bill, or Rodell, or Patrick, or Stephanie, or whomever, I think I want to put some monkey lungs in a flask and see what happens there. I think we'd all look at him about this way, all right? Like, what the heck are you talking about? But this is the pump that ultimately was the first used for a bypass procedure. On the left side, what you see is a replica of the original DeBakey roller pump. With that, Michael DeBakey of the Houston Methodist Hospital developed as a medical student in 1923. The original of this is in the Smithsonian Museum. So keep that in mind. Okay, 1923. And what it was for delivering or either giving blood to the patient or something to the patient or taking blood from the patient. And of course, it had a raceway with a stroke volume and it had a counter, very simple design. But that design, that simple design has endured. We use DeBakey roller pumps to this day on our heart-lung machines. And anyway, on the right side, you see what is the Gibbon IBM heart-lung machine Model 2. Now, the screens are on the upper left. You see them sticking up right there. But IBM, not only General Motors, but IBM was involved in this. And many people said this device looked like a punch card business machine, and which I'll show you a picture of. But this was a very sophisticated device for its day. It weighed over 2,000 pounds. It had wheels. It was a ton, okay? This wasn't just some light machine. This thing had nitrogen bottles that flooded the area to avoid explosion risk. It had pH sensors. It had pressure sensors. So for its time, 1953, this was a highly sophisticated device. And here is that punch card business machine circa 1950. You see the similarity. It's so incredibly interesting to me that General Motors, their pump looked like a car motor. IBM Gibbon pump, or Gibbon IBM Model 2, looked like a business machine. Anyway, here is Dr. Gibbon and his wife, Mary Gibbon, on the left. On the right, you see Mary Gibbon doing a procedure with Dr. John Gibbon, one of the four, perhaps, that he did. The first successful one, of course, was in 1953 at Thomas Jefferson University in Philadelphia, and it was for an 18-year-old ASD. Cecilia Bavalik was her name, and, of course, a collaboration with IBM. See what's happening. I need to switch my slide. There you go. So, Dr. Gibbon did 4 total cases. The first one died. The second one died. The third, Cecilia Bavalik, survived. The fourth one died. And he never did another procedure with the use of the heart-lung machine. He turned the project over to a colleague. So the guy that worked his entire life in the development of this device used it one time successfully, but only 4 times in total. So they needed somebody to run these pumps because the age of the heart-lung machine and extracorporeal circulation was taking off at this point. They were successful. It wasn't going to stop. They needed it to fix all these things. And so they needed to find people who could do this. And that's how perfusionists, the profession of perfusion, was born. In 1971, the first formal perfusion training center was opened at Texas Heart Institute, and it was chaired by Charlie Reed. We all know Charlie Reed. He was also the first president of our professional society, and he was also the first president of our certifying body, the ABCP, who accreditates these programs for Category 1 CEUs. They looked for these qualities: independence, fearless, being a great communicator, being thick-skinned, because it's a full contact sport in there. I think we all know that. Being mechanically inclined. In fact, there's a lot of biomedical engineers who have perfusion degrees, which is interesting. But that's how it used to be. That was big back then. They wanted to be creative and industrious. You had to figure circuits out, innovative, durable, because the hours were horrible. They still are. Being inquisitive, being adaptable, being interested in what's going on, being a quick thinker, and most of all, you wanted to be a doer. That's what they looked for. That mattered a lot. So, contemporary realities of our profession now is that cabbages and valves are our bread and butter. The volume of these cases, however, has plummeted since the heyday where we used to do, I was working during this time, 700,000 cabbages a year to now under 200,000. It was like 180-something thousand in the last couple of years ago. There's roughly 4,135 perfusionists in the U.S. That number is actually higher because when I mailed all of you those flyers, I give them to the ABCP and they mail them out for me to your locations. And I think I had to give them for a little over 4,000 to a little under 4,300. So the number of perfusionists actually is increasing. And my conversation with Ed Evans the other day, he told me that they were graduating 32 students this year. 32. So you've got that school, that Midwestern, that's where he is, in Glendale, Arizona, or Scottsdale, one or the other. There's, of course, University of North Carolina, Charleston. You've got Shadyside. You've got the Cleveland Clinic program. You have THI, of course. You have the new program here at Memorial. There's been a lot of discussion about us being in a relative shortage of perfusionists. Of course, I don't really feel like we have been in a shortage. I think that the numbers are really kind of right to be able to maximize our professional lobbying power. We're an extremely small fraternity. We don't have the AMA where heart surgeons can be part of a physician thing. Because there's only about 5,000 heart surgeons in the country as well. But so we're both very small fraternities, but they can be a part of something bigger. There's over 3 million nurses. They have huge lobbying power. We're very small fraternity, a very important one who most people have no clue what we are, who we are, what we do, but yet we're awfully important. We are truly an integral part of that overall heart care team. We're an enigma. We're so important, but we're an enigma. Okay, keep that in mind. But we are embattled over TAVRs. Obviously, that's going to drive heart volume down, the number of cases that we're doing in open aortic valve, and ultimately, I think mitral valves as well. But are we our own worst enemies? And why do I say that? Okay, so here's the graphic of the number of perfusionists. Well, let's take a look here. Here is today's perfusionist with his or her head in the sand saying, please tell me everything is going to be okay. You have technology that is just barreling down And if we're not learning, if we're not growing, we're dying. Those are just, I think, harsh. That's my opinion, but I think that's an opinion that's shared by a lot of people. And there's progress. Oh, don't worry, everything will just be fine. But it's not going to be. Technology is going to keep coming, eat the bird, us, and just go on their way. So how it used to be, and I'd love to have a webinar with some students maybe from the past, maybe some program directors, if anybody's watching this. I'd love to talk about the type of training that's done now compared to the training that was done when I went to school, and many of my contemporaries went to school. But listen, I could harvest vein, I could put radial arterial lines in, I first assisted, I did pump. We did everything, okay? But it wasn't until 1982, believe it or not, first time that I heard about a cell saver. And at the time, it was exclusively a perfusion device, okay? There was no such thing as an autotransfusionist back in those days. There were only perfusionists, that's it. Well, how it used to be, we did our cases, we used to cover IABP, ECMO, VADS, ATS, and we were very eager to adopt anything new. But somewhere, and I don't know where, and I don't even know why, that seems to have changed, okay? And now we find ourselves, well, scratching our heads. What are we going to do? Heart volume, on-pump case volume is, in fact, decreasing. Will they ever find I think I dropped my mic. Will they ever find a magic pill, a panacea to coronary heart disease? Probably not in my lifetime, but, you know, with genetics and things, I mean, it could very well happen. But there are so many other new technologies that are extracorporeal in nature that we should be really investing in understanding and learning how to use it and incorporating it into our practices so that we do not become extinct. This is how I feel about it. So in the early 70s, there were about 300 to 400 centers that were doing heart surgery. In the 1990s, that increased to about 850, and today, there's 1,150. If there was ever a shortage, this is probably more the reason why. You know, of course, you're going to have attrition. People are going to get just burned out of the business and leave. You're going to get the retirees that are going to, old people like me that probably should have retired a few years ago, but I got to make it my 40. I got to do 40 at least. You know, other variety of reasons why people are not in the profession. But I think that when you have a buildup of so many community hospitals that just do a few cases to support a cath lab or a TAVR program or whatever they want to do, then I think it makes it real hard to have enough perfusionists, and it makes it doubly hard for those perfusionists in particular to get coverage, to go to meetings, to get enough CEUs to keep their certification. I mean, these are stories that I actually hear from people, so it's real, and if you're watching and one of those people, then this may resonate. If you're in a big program somewhere where you never had to worry about this, you may not, but you do need to at least be aware of it and be thinking about it. Now, what we see here is a graphic. Basically, if you look at these lines here, this is the number of centers going up, and here's the number of procedures going down. And if you look here, very high volume programs are going this way, up and then down, and very low volume programs are down low and then eventually catching up and surpassing the very large programs. So that's just a diagrammatic way of expressing what I just got through saying. Now, in this particular picture that you see here, the purple line is the growth of the population projected out to 2030, that it will be over the age of 65. But the red line is if the number of heart surgeons currently existing and being trained, where they will be. just from regular attrition and from replacement from training. If you take the blue line and train 150 heart surgeons a year, you'll end up looking like that, still an insufficient amount. And if you take a look at the green line, then that's 75 a year. Now, here's the problem. A lot of heart surgery programs can't get their programs filled. They don't have people wanting to become heart surgeons. And I fear that this slide that I stole from Dr. Mack is, you can say, will operate for food. It's his original slide, but that probably should say, will pump for slide, or could say that as well. And then this I also stole from Dr. Mack. And here's the Cardiac Surgeon Express, and it's a cardiology view of the cardiac surgeon. Well, is that the heart surgeon's view of the perfusionist? Is that the hospital administrator's view of the perfusionist? I think we need to take that seriously and into consideration. Dr. Mack also goes on to explain in this article that minimally invasive and robotic surgery, there's a lot of surgeons coming out of programs right now that would have a hard time doing a procedure open. They're used to doing everything minimally invasive and or robotic. And I think that's interesting. But we need to start figuring out, how can we be part of the minimally invasive and robotic surgery? How can the pump be incorporated in this? Because right now, the way they're looking at it is to do this and not need the pump. That has been the goal for a very long time. And it's one that bothers me quite a bit because, frankly, I think that, not just because I have a bias that I'm a perfusionist and I need people to want to use the pump in order to have a job and to earn my living, but I do truly believe that the heart-lung machine, the pump, as it continues to evolve, can do open so many doors to so many different therapies. We just need to figure that out. Somebody smarter than me needs to help figure that out. Now, perfusion training. If you take a look at this graph from left to right, you see that the number of training programs grew from 1984 and then dropped off, and out in 2015, it's somewhere around 17. So the number of training programs definitely has almost gone back to baseline from 1984. When you look at this graphic, a couple of new programs came up, but some really big, important programs closed down, like Ohio State, which I would have never thought that the Ohio State University School of Perfusion would have ever closed down, but it in fact did. So that's something I think we need to be thinking about. You know, these training programs open up, but what are they teaching? There's one program, I won't mention the name of it, but they almost the entirety of their training, all of the cases that they get to sit for their boards comes exclusively from ECMO. I mean, is that really a legitimate way to train people? Is that fair to that person that's becoming a perfusionist? Is that fair to the employers that are going to hire that person? And is that fair to the patients? I don't think so. But again, I'm never shy of my opinion, and you know, I'd like to know what yours is. I think it's a good point to discuss. So over here, you take a look, and in 2001, 131 people were admitted to perfusion school. In 2013, that number was 159. The lowest graduation rate was in 2007 with 81.62, and the lowest employment rate was in 2005 with 88.7%. But you see here, it's not 100%. Even in 2013, it was 97%. There were some people not getting jobs. Was that because they should have never passed perfusion school, or was that because there was no job? I really don't know the answer to that, but it's certainly something I think provocative that needs to be vetted out and figured out. Now we look at this graph here, and you see that the age, I circled the one less than 25 because look at the number of people. 59 of the 139 perfusionists, the people that entered perfusion school, were under the age of 25. which means they are investing a lot of time and a lot of money to learn a profession that I think we, as the older generation and the mid-generation, the panel that's going to be up here, I consider them kind of mid-career, we need to take this seriously and let them have a profession when this is over. Because they're investing all of this time and energy and money to learn a craft. We don't want to see that disappear for them. They've got 30 years of practice or more, at least. So something else to consider, I think. So I want to show you these names. These are some people who I think are just very notable. Of course, Charlie Reed, James Deering, Jerry Dobbs. Jerry Dobbs, for those of you who don't know, recently passed, and he was just one of the nicest, kindest people. He was kind enough to give me his website, perfusioneducation.com. He used to do podcasts. I was one of his first interviews that he did, and he just asked me to do something good with the website. And since his passing, we have been working really hard at building something I think is going to be very I'm going to be very proud of it, and I think I think a lot of people are going to enjoy the website, and hopefully Jerry's looking from the big pump up in the sky, and he'll enjoy it too. But these are some real interesting folks that were around. Mike Burgess, for anybody that didn't know Mike Burgess, he was born on Catalina Island in California, and he was pretty wild. Charlie was pretty wild too, though. But interesting folks. So for those of you who may have never seen this, this is what the oxygenators and pumps used to look like. This is the actual pump and oxygenator that I trained on in 1977. I started my training in 1977. And of course, you know, we know that this is how they look today, pretty sophisticated, nice looking devices. And this is what the oxygenators look like, you know, with some variability, but you can tell the sophistication of these things has vastly improved. This is, of course, what the operating rooms of the past looked like. That is Dr. Cooley's operating room, and he is there somewhere. But he is there, trust me, he really is. But this is what it used to look like when we did heart surgery. But it's become so commonplace. This is what the heart surgery, the rooms look like, the rooms of now. And it never ceases to, this picture, I love this picture. If you look here, this is very important. The surgeon, let's see, right here, he is working, he's just focused on what he's doing. He's wearing his loops. The nurse is paying attention so she can hand him whatever might need to be handled, or the surgical tech. Look at this perfusionist. I love this guy. He is just laser focused. He still sees everything, but laser focused. And he's making some change here. But look at anesthesia. Like they always do, looking over the screen, trying to figure out, what the heck is that guy doing? What is Joe doing now? What is he doing? So they don't know. They have no clue. Most people just have no clue what we're doing. But look, this is about us being able to win as a profession. I'll give you this this little...
So much winning, if I get elected, that you may get bored with winning. Believe me. I agree. You'll never get bored with winning. We never get bored.
Never get bored. Never get bored. No, never get bored. So, new and emerging technologies. Look, ECMO has grown 400% in the past 4 or 5 years. It is skyrocketing, and it's going to continue to go up. The way we're doing ECMO is not bad. You know, we've got 60% roughly, anywhere between, on VV, somewhere between 50 and 60% survival, which is, you know, I mean, great compared to what it used to be, right? But VA ECMO still languishes down in the survival rate of about 5%. It's pretty low. The AngioVac, don't know how many people are familiar with it. If you come to the New Orleans conference, you know I always have it there. I've done some AngioVac cases. I think it has great utility, and it is a tool that perfusionists should be using all the time, looking for cases, talking with the interventional radiologist, talking to the cardiologists, whoever is handling cases for the removal of unwanted intravascular material. I have used it for removing occluded vena cava filters and inferior vena cava iliac thrombosis. I've used it for removing a vegetation off of a catheter that was in the right atrium, and I've used it on a case that removed a clot from the aorta. Now, it's not approved for intra-arterial use. It is intravenous use, but used off-label, and we removed a big clot that was dangling off of the where the takeoff of the left subclavian was, and sucked it right out. Very impressive technology. We need to be more involved with this. So, perfusion can watch ECMO. Nursing can watch ECMO. Respiratory care can watch ECMO. PBMTs can watch ECMO in some places. I don't think that makes any sense, but that's a different issue. High resource utilization. It is, however, a revenue source, though if done poorly, the hospital will lose a lot of money, but it is high resource utilization. And questions remain as to whether it should be a sole perfusion responsibility or not. It does count towards your ABC case requirement. An initiation is one case. 8 hours of monitoring is one case. So keep that in mind if you didn't know that. But I have really struggled with this because I have historically believed that ECMO should only be a perfusion run at the bedside device. However, the realities of it are, I don't think it is a sustainable model for a variety of reasons, some of which are there aren't enough of us. The amount of ECMOs going up, it's going to continue to go up, and we can't produce enough perfusionists because they'll be sitting around most of the year doing nothing unless they get a code or we get a flu or whatever it might be. So ECMO is a very seasonal and up and down kind of therapy, not something that just can be scheduled and is routine. So I think, my opinion is changing on this, and I think that to keep involved, not control, I don't want to use that word, in order for us to maintain involvement, because I do think we are the best trained, most experienced people to understand ECMO as a circuit. I think that we need to be part of the change. I think nurse ECMO specialists just make sense. I think they're very capable. I'm more comfortable with them than respiratory therapy. Not that respiratory therapists aren't smart people. I just don't think that they have the experience in managing patients, bleeding, coagulopathies, transfusions, pressors, inotropes, whatever, taking nutrition, taking care of the patient as a whole. They're very focused just on the ventilator. I think they're smart. I think they do that very well, but I don't really feel that they are experienced enough in caring for the patient to do it. So I'm thinking nurse ECMO specialist is going to be the way this is going to go. I think it's unavoidable, and I think we need to be part of it, not have it imposed upon us. That's something that I'm concerned about too. Now, here's that article that I told you about, 433% increase in ECMO. And here we just show a graph of the same thing. Of course, ECMO has gotten really good with VV, and you have the Avalon catheter. I don't have a picture of the Protect Duo catheter, but that's from Tandem Heart. Tandem Heart was just bought by LivaNova, and I think that was a move made because LivaNova knows that the ECMO market is going to increase. So I don't think there's any question in anybody's mind, but the Protect Duo is a catheter that goes in through the IJ and sits in the pulmonary artery. So your access, it has two ports. The access port, or dual lumen, the access port is in the right atrium, and the return is in the pulmonary artery, eliminating the risk of recirculation, but more of a challenge to put in than would this be. This has much more recirculation associated with it. That has that. Both catheters are very expensive. There's all different kinds of, we're not going to talk about cannulation techniques here today. We will have that discussion, however. But ECMO survival, well, there is no benefit. I think that the studies, interesting studies, and I just had Dr. Skipper here the other night, survival off ECMO for VV is roughly 60%. But long-term survival, with it or without it, in some studies that have been done, there was no difference. And I've had some intensive care medicine doctors tell me no one's ever been saved from ECMO. I don't believe that, but the data really is not that compelling. But I think part of the problem is there hasn't been a really good study with a good study design to document that. We might not be doing it right. We might be able to get better results if we did it something differently. I don't know what that is, but I think there are some things. Certainly change the way we're anticoagulating these people now, that's for sure. Which patients will benefit? Look, earlier initiation, better outcomes, timing, technical issues, and then of course these other things that you see here. The AngioVac, currently solely a perfusion practice. We've got to keep it. We have to expand it. I'm telling you, this is a very, very good tool for our toolbox. But it is in its very early stages of initiation. I don't know if you've ever seen this, but I'm going to show you it running.
This procedure is a minimally invasive technique where we access the veins, often in the neck, the two largest veins in your neck on the side, and we put a cannula down into the clot, and we essentially vacuum out the clot in the IVC, which is the largest vein in your abdomen, which drains all the blood from your legs and your pelvis. Once we unclog that vein, we then continue to remove the clot in the pelvis and then continue down in the legs until we've removed all the clot from the knees all the way to the heart. Most of the procedures are done with X-ray guidance, meaning it's much like a video game where we're watching the device on a screen as we're manipulating it with our hand, which goes through a very small incision in the vessel. So this is the AngioVac aspiration catheter, and this is the device that we put in the neck that actually aspirates the clot from the veins. Although it's very large, the vein in the neck is about twice this size. So it's got an expandable tip that literally acts like a large cone on a vacuum that will reach down and remove the clot directly. It then extends through a filter, and then the blood is given back to the patient. So the procedure itself can take anywhere from about 2 hours to 3 hours. Most of that is preparation. The actual patient being under anesthesia is about half that time. Most of our patients have had incredible outcomes. We've had some patients that hadn't walked in 2 months and have been sitting in other hospitals on.
So that chatter that you saw was engaging the clot. And that's sort of a visual cue. I think the device is really, really, really neat. CVVH and MARS and TPE, therapeutic plasma exchange. MARS is molecular adsorption recirculation system used for, let's say you have shock liver, or a patient had a liver transplant, was a donor, and they went into acute hepatic failure. You can put them on this if somebody has gross systemic inflammatory response syndrome. This is a device, a technology that can be beneficial, and of course CVVH for acute kidney injury and acute renal failure, or for maintenance of homeostasis. It could be an acid-base imbalance, an electrolyte imbalance, anything. So it's not dialysis. They call it dialysis. It has been in the purview of the dialysis people for some reason. When it was developed and when it was marketed. I think this is something that needs to be really looked at by my perfusion colleagues and in the open heart arena, because I think that it is a device we can be using post-op on patients. You can use it pre-op. You have a patient that has a contrast nephropathy. There's a protocol for that. You put them on CVVH for 2 days. You do the procedure, 1 day post-op on CVVH, and you're done. And the risk of developing further nephropathies is greatly reduced. So a patient really does need surgery. This is a good way to accomplish that without hurting the kidneys even further after they've taken a hit from the contrast, okay? And let me show you what that looks like. So this is really something. This patient, and I guess they don't have HIPAA wherever country this is, because they took some videos. This picture, this video, that's CVVH. And just wait for it, just to show you how much technology you can stuff in a patient. And those are the replacement fluid bags that you see down there. So you're ultrafiltrating plasma water, just like we're doing MUF on the pump. You're ultrafiltrating the plasma water and replacing it with plasma water that you want the blood to look like. And there's the patient on the ventilator. We could throw they have the Vigileo system, or whichever one that is. Doesn't look like we have an arterial line, but got a ventilator, nice looking ventilator. But wait for it, look at that other side. They are doing both CVVH and liver dialysis, or MARS, on this patient. Both at the same time. So I think there's many other opportunities. This is minimally invasive. This is an article that I wrote. I think it's a good article, and I think it shows some of the stuff that we can do to deal with the minimally invasive world. But of course, we've got heart transplants. It's beating hearts now, transporting on while the heart is actually beating and still perfused, the lungs being ventilated. I think we need to be more involved in things like that. Congestive heart failure therapies, cancer therapies, isolated limb, liver, peritoneal, full body. You know, they do the shake and bake with the peritoneal dialysis. Improving minimally invasive techniques with my hyperkalemia technique and transcranial Doppler. I mean, you know, what was his name? Gosh dog it, I'm blanking out on his name now. The fellow that was, I used to think the guy was full of it. I thought he was crazy when he was doing TCD, but TCD machines have gotten much better. But he was absolutely right. Doggone it, I can't remember his name, but it'll come to me later. But nevertheless, I think we should be monitoring TCD. I did a talk on TCD versus other technologies to determine whether or not we are adequately perfusing the brain. You know, we're perfusionists. We put patients on pump. The leg can last a pretty good long while without adequate perfusion. But I'll tell you what can't last is the brain. And I think we don't do a good job. Cerebral oximetry, forget about it. You can use it and you can think you're doing something good, but you aren't. If you really delve into what that technology is, you want to get TCD. So we have some of our own interest interfering, leadership as it compares to others within our profession. I don't think our professional organization or society is doing as good a job as I think they could at representing our profession. I think licensure was a debacle, but we can have that discussion too a little bit later. But we personally are not without fault. Look, individually as a perfusionist, we are an expense, not a revenue source for the hospital. We have sometimes a mentality, out by noon with no balloon. It's a job, not a profession. And we push back being asked to do other things. We've got to change that. And should we change the educational requirements for perfusionists? I mean, I don't know. I don't know, but these are, I think, provocative questions, and I mean to be provocative. I mean for people to feel uncomfortable. I want to know what you all think. So I think we need to be a part of the revolution, or we can become extinct. Now, I have a really cute video that's takes a little bit of time. I'm not going to show that video now. I'm going to go ahead and stop this. We're going to go into a quick commercial break. When we come back from the commercial break, I'm going to bring up our panelists, Rodell and Patrick, and we're going to go from there. Thank you all very much for your patience here. Okay, and welcome back. Phone lines are open. Roger's going to put the number up in case you didn't know it. I've got the phone right here. We've paid the bill and we've tested it, so we know it's working. So don't hesitate to call in if you want to be part of this discussion or you just simply have a question. Now, to my right, of course, you all know Patrick O'Toole. You've seen him before. He's been here a couple of times. Great guy. Rodell Ebus, Perfusionist, also been here many times as well. These are two tenured, seasoned perfusionists working here in the Houston area. And I think that, you know, as I said earlier, I would say you guys are sort of mid-career. I'm kind of end of career. You know, and I think that you guys may have some interesting perspectives. Let's just start it off with, what did you think of my talk?
I'll start. I thought it was good. I actually have a question.
Great would have been better, but that's all right.
I was.
You
I
were
was thinking.
you were made employee of the quarter yesterday.
Yes,
True.
that's
That's
correct.
true. We're going to talk about that, I think, too.
Employee of the
So
quarter.
I
He's
am
got
employee
a
of the
great
quarter.
story. You want
Yeah,
to talk about
yeah.
stories? I'm going to tell the story, but ask your
Yeah.
question
You're gonna
first.
tell the story?
Yes, I'm going to tell the story right now,
Okay.
live in front of everybody.
Okay. But I was thinking about angiovac, and I first off, I don't know what the population, how many people have thrombosis is in their vena cava that need to be
lot.
removed. It's
A
a lot.
lot.
Huh?
A lot.
Yes.
And so the current procedures, I guess, would be like giving TPA, and how are they treated other than angiovac?
Heparin, put a filter in them, send them home.
Okay, so I would think that the population for patients who have DVT is even higher. And I wonder if angiovac couldn't be used to somehow remedy that. Because we know it's a
Are the
big problem.
cannulas too big?
Well, it is too big.
You're
but
gonna,
it's
I
not-
think the cannons
if you
are a
have
little too big.
DVT, you're
Right.
getting a filter and you're going to be put on
Right.
Xarelto or something like that, or some one of these newfangled, either Coumadin, or you're going to be put on one of the novel, anticoagulants you see advertised all of
Yeah.
the time, so that you can still eat green vegetables and stuff, factor 10 inhibitors.
Yeah.
But and that was another thing. I had but there's a lot of procedures where this is. Look, there are a lot of vegetations on tricuspid valves that we open those patients to remove.
Mm-hmm.
This could be used for that. You have line sepsis and vegetation that can be a problem. Clot, you don't want to break the clot off, taking the line out and give them a PE, so this is an alternative to that. Venous, ilio IVC thrombosis is not an uncommon phenomenon. It's usually being dealt with, however, in the radiology suite, interestingly enough. And our heart surgeons, they don't want to deal with it because these can be some long cases at times. They're not going to deal with this. Cardiologists will deal with it. I did them for Dr. Nasser.
That's right.
Over at St. Luke's. And that procedure was very successful. You saw the before and after.
Oh, yeah.
I mean, we've got the experience with the devices.
Right.
I've done a case with him in removing an occluded IVC iliac system with an occluded IVC filter that we were able to safely remove, which was huge for this patient. So, I mean, I think there's a lot of benefit to it. But I do want to tell the story. So, Patrick is HET's employee of the quarter. Why is that? What did Patrick do so special? So Patrick was not on call and gets a call that the call person is probably 30 minutes from the hospital, and there is a patient who has been stabbed in the chest through and through the pulmonary artery and needs to go on pump a lot sooner than 30 minutes. So the 30 minutes to get there plus setup time, so we could be talking an hour here. And the patient, although was 22 years old, was still somewhat aware.
He was conscious.
He was conscious, but he was certainly, when he's 22,
Right.
but he was certainly in peril. So Patrick went in, crashed the patient on pump, surgeon started operating quickly, got the kid through the procedure, fixed everything, sent him to the ICU. 3 days later, Patrick decides to go see the kid, see how he's doing. Oh no, second day. And they were getting ready to discharge him, second or third day, whichever it was. Third day, post-op, just send him home. And of course, Patrick wanted to know what happened. So he told him what happened. The kid told him, well, I'm married and I was dating this girl who didn't know I was married, and one day I decided, I guess, that I needed to tell her that I was married, so I told her I was married, and Patrick, being Patrick, said, well, when you told her this, where were you? And he said, well, I was in the kitchen. So bad idea. If you ever have to do that, don't do it in the kitchen. But the knife was like this big.
It had to be because it was almost to the spine.
Wow,
so,
and she just stuck him. And he says he doesn't remember anything after that. But
he remembers her grabbing the knife, and he was going to try to grab her wrist, but he lost his balance or something, and that's the last thing he remembers.
But the loving couple is getting together because, of course, his wife doesn't want anything to do with him, and I think they've reconciled this, and they're going to go on and have a happy life together.
That's what he said. He said he really loves her, and he's going to go. And I mentioned this story to someone else, and they said Min's been on the show, I think. I can't remember when, but I think a colleague of mine, I told him, and he's going to get back together with the girlfriend. He's divorcing the wife now. And Min said, well, of course. I said, what's the logic here? He said, because the wife, she's going to hate him forever.
Sure.
But the girlfriend, he forgave her, and so, she's kind of going to owe him forever. And she's always going to see that big scar on his chest and everything. And I said, I guess that makes some sense in some way.
Okay, there's some male logic there.
Yeah, that's Vietnamese logic.
That's
Vietnamese logic.
Okay.
I could see Min saying that.
Oh, for goodness sake.
Yeah. So anyway, that's my thoughts. But that's Patrick. So, what was your thoughts of the talk, the various things, the CVVH? Well, let me ask you this: you were involved in training students.
Yes.
Are we really training people the way we should be?
That's a good question. I think we are. I think schools are getting better at embracing technology. We were always, always talking about a simulator when I was in school. What we had was just this IBM computer, and it had a few, devices that we can click on the screen, and it wouldn't give us too much of a feedback. I mean, it would just say, it would pop up on the screen your lab values. Now we actually have like simulators that really occlude the volume that's coming back to you. I mean, it's a true physical simulation, and a lot of schools nowadays are using those simulators well before they actually get into the OR and work on a human being, which is, I think, phenomenal. I mean, we had a wet lab at Texas Heart, and it literally was an old pump, and we'd prime it up in a closet. I mean, that's as archaic as it gets, but it was effective. I'm not saying that it was ineffective. Our instructors would do something to the pump, and we'd try to figure out what was going on with that pump with our limited, education. So now it's a lot more sophisticated. I mean, not everybody does all of the CRRT, or ECMO. You mentioned a school that actually does do their education mostly with ECMO, which was kind of interesting. I don't know what.
Yeah, I don't want to say. I'm not going to say.
Yeah, I'm not going to delve into it. But that was quite interesting
I think
because
you should delve into it, because I don't think that is legitimate. I truly feel that is fundamentally wrong.
Yeah, I think it should be part of the education, because when I was in school, I saw an ECMO. I mean, I didn't have anything to do with it. We didn't initiate it. We went to a sister hospital, walked over, looked at it, talked about the components, but that was it.
And that makes no sense to me whatsoever.
I mean, ECMO was not the nouveau technique. I mean, again, this was 18 years ago.
Well,
but it wasn't the choice of therapy.
But I don't think you're seeing it today. I know a lot of people who are relatively young in their, that post-training, who I've spoke to, who they didn't do ECMO in school, and they don't do ECMO where they are. What are they going to do?
Yeah, and that's
because it is such a. I think I do not view ECMO. I want to get your thoughts on it. I don't view ECMO as just a little mini bypass pump.
No,
it is, but it's kind of like pediatric versus adult.
Right.
Okay. Pediatric perfusionists. I don't know how y'all do it. If any of you are watching,
you guys are the cream of the crop, by the way.
Do it. I don't think they're cream of the crop. I think they're crazy because I couldn't take the stress. But I have been duly counseled by pediatric perfusionists and told they are not little adults.
Right.
ECMOs are not your typical open heart case that we put on pump. They're sicker, generally speaking.
Right.
They have a lot of them are infected, but they're in really dire straits. And it's going to be not like a crash on pump where we're going to try to fix this and they don't make it, or we put them on ECMO and take them to the ICU. But it's not just a a heart, a little mini heart case that's in the ICU. What's your thoughts on that?
Well, I agree. It's not a mini heart case. For one, there's no surgery going on, and it's a whole different kind of management of a patient, because it's not. It's something where you have to make decisions by the day rather than by the minute. Because in surgery, you're shifting volumes and changing things all the time. So ECMO patients are very different, and I think that we do. I don't know how many ECMOs. I would guess 14 a year, maybe. To 20? I don't know how many we do.
Yeah, probably so.
Around there.
That's about right.
Yeah. And the programs that do it more often, the hospitals that do it more often, we see much better success. So there's definitely something going on there with the management of the patient. And I would say one problem with ECMO at some places that we do it at is that we don't have that management. Maybe the surgeon just puts it in, and then we don't see that surgeon anymore. And the pulmonologist comes by, but maybe doesn't know that. I've had pulmonologists ask me all kinds of questions about ECMO, so they don't really know what's going on.
Right.
And so there's no one to make that decision to wean when we should wean. And we all here have seen that there's a window that lasts about 24 hours.
Yes.
And when that window's gone, you're going septic and you're going to bleed.
Right. Right. Yeah, that's exactly right. I think you're exactly right. And I don't think it's just that. So let me ask you this. I feel very strongly, and a couple of people have talked. Actually, some of the evaluations said they're real interested in understanding or talking more about antegrade versus retrograde cerebral perfusion, isolated cerebral perfusion. Somebody had mentioned, which I'd never heard of, whole body retrograde perfusion. Can that even be done? I don't even know if that's possible.
Yeah,
I really truly don't know.
If anybody knows anything about that, they
please,
should call in.
Please call in.
I
would like to know.
I would love to know about that. But also north-south phenomenon or dual circulation, however you want to couch it, where you're cannulated fem-fem on a VA ECMO, the lungs are trashed, the heart's still working pretty well, and you end up with a PO2 of 30 in the head and 300 in the
in the
diaphragm and below. So how do we manage that? That was on the evaluations. Staffing, how are we managing that? What are we going to do with all of this stuff? There was some really good stuff.
Yeah, that's been a huge topic, is with staffing. Everybody's across the board with it. I just recently came back from a conference, and and then talking with some of the colleagues, after the talks, and nobody knows. I mean, everybody's across the board with it. Like, a lot of people are saying, "Hey, we cannot give this up," which I'm in that camp, because I think we have the expertise, but is it feasible? We've talked about that. I mean, do we have enough staff to run hearts as well as the ECMOs? Because ECMOs,
we do and we don't.
We do and we don't.
We do and we don't.
Right.
That's part of the challenge.
It's the ebb and flow.
Hey, excuse me one second. Hey, Raj, I'm not able to get this on YouTube right now. Is there an issue going on with YouTube? I'm not sure. It may be my computer. I don't know. But also, what's the number to the call-in? Somebody's texting me personally asking.
281.
Hold on. Let me put it on here. 281. 738.
7906.
738-7906.
On the back of that phone?
Thanks. Yeah, they're texting me, asking me. But I don't know what's going on. Is anybody monitoring YouTube? Is it working? It is working?
Yeah, we got it.
Okay, well, it's just my computer. Okay, I'm sorry.
So,
okay, go ahead. I'm sorry.
Oh, yeah. Well, I was thinking about what you said about staffing and for ECMO. And the real problem is that it is seasonal. It's so seasonal. For us, it is anyway.
It is.
We come into
flu season.
November is about when it starts, and it's over. Not over, but it's pretty well cleared up by March. So if you Google, because I've done this, if you Google ECMO coverage, because I made a presentation on ECMO coverage.
Yes,
and
I've done that too.
You're going to see a lot of temporary ECMO service providers, people who will say, we will fly to your city and we will cover your ECMO for you.
Yep,
for
there's
like
ProCirca,
$500 an hour or something crazy.
There's ProCirca, there's ECMO Advantage. Those are the two that I saw. But yeah, there's companies, and what they're doing is now is using. If you want perfusionist, we'll send you perfusionist. If you want nurse specialist, we'll send you nurse specialist, ECMO specialist that's been trained. And if you want a respiratory therapist, we'll send that. And they're charging different rates depending on who you get. Perfusionists are the most expensive, and most places aren't, in fact, using. In fact, ECMO Advantage was started by and is run by a respiratory therapist.
Oh,
there's not a perfusionist in the company.
Oh, wow.
I just wonder what those people
that
who
I'm
are
aware of. I mean,
Yeah.
I don't want to say I'm 100% sure.
the people who are providing the coverage. I wonder what they do the rest of the year when they're not in the ECMO season.
It's just like a per diem kind of deal.
Well, but I think there's a lot of institutions that have staffing difficulties, and I think those institutions have ECMO going a lot. I think I don't think you can really translate or project our kind of practice here and how it works for us into how it works for everybody else around the country. There are places where they have ECMO going year round, and they simply don't have enough staff, or somebody's on vacation, or somebody gets sick, or they have attrition, somebody quits, whatever it may be. So that is something I think that happens not too infrequently. And they also do training, a lot of it.
Sure. A lot of training.
A lot of training. Now, what do you think of TCD? Do you think we should be monitoring TCD on every heart case?
Well, the question is, would it change what we do during the pump run? That's. I mean, if we did monitor it, would it change what we do on the pump run? And I have an example of something kind of similar to that, where the heart-lung machine that we use has the ability to detect micro bubbles, and you can set a little alarm, an audible alarm. It's not the same alarm as an emergency alarm, but it's just a different kind of tone, and it will tell you whenever you're delivering micro air. And when I used to train people how to run that heart-lung machine, I would tell them, once you're used to the machine, turn this on, and it will change the way you do perfusion, because little things you're doing, like injecting a drug even into the venous side or whatever, you're gonna hear that little noise, and you're gonna realize, oh, look what I just did. So I think more monitoring, to get back to the TCD question, I think more monitoring is a good thing if it's going to change how you practice perfusion. And it seems to me from the talk that we got from Zolt Garami really showed that it would change the way we do things.
I think so too. Well, let me ask you a question. Ask both of you. I want your answer to this, okay? Just sort of listening to what you just said. When you go down on the flow, when they're putting the clamp on, removing the clamp, or whatever it may be, do you turn the rheostat control down, or do you clamp the tube?
You go first.
Oh, I use the rheostat. Because I was a roller pump guy for many years.
Okay, well that explains that. Yeah. How do you do it?
I now do both. I turn it down and clamp so I don't get retrograde flow.
Okay, but
there have times in the past when I've just clamped it, but I then became afraid of blowing a line off.
Okay, so with that said, there are two camps of perfusionists. There are those that just clamp it.
Yeah.
They just clamp it completely.
Right. Yeah.
Right.
I've seen them clamp it completely off.
I've seen it.
Okay, not just little clamp it.
Yes.
Clamped. And then there's those like me and I think you guys that turn the rheostat control down and turn it down and turn it back up. If every time you clamped it or every time you turned the rheostat control up and down, if either of those that you did resulted in embolic events, showers on your TCD, would you change what you're doing?
Yes.
Absolutely.
Okay.
Absolutely.
So with that said, your question to me was, would it change your practice?
Yeah.
Right.
But what you don't know can kill you.
Yes.
Or someone.
Well, not you, someone. Yeah,
Right, yeah.
That's the beauty of that's
Right.
that's the safety of perfusion versus being an airline pilot. You die too there.
Yes.
Right.
So with that said, unless you're a cruise ship captain and you're in Italy and you just leave everybody and jump off the boat, save yourself. Okay,
Ouch.
airline pilots.
Ouch.
Airline pilots
Yeah,
can't
yeah,
do
yeah.
that. But I do think that knowledge is power, and I think having, excuse me, having the information is beneficial to how we do things. Let's just say the surgeon, I don't know, something that they do routinely during the procedure, and it results in a problem, a shower of emboli, or a reduction in flow, or reversal of flow, or something. Would awareness of that make them do something different? If they're pulling the heart over, trying to do a certain rep, and you know how it affects our flow,
Yes.
right? Well, it affects the flow because it's restricting the SVC, and the head is getting engorged, and your venous side pressure is going up. And if you don't have a good capillary opening pressure to overcome that, well, guess what? You're going to lose flow to the brain.
Right.
Okay? So if we knew that, so we tell them our flow's horrible. We're really down on the flow. Just deal with it. Just deal with it. Just deal with it. But if we said to him, the brain is not getting blood flow.
Yeah. Now we have a tool. Now we actually have a diagnostic tool.
Be much more likely
Yes.
to put the heart down
Yes.
and figure out something else.
No, we're going to want to make sure that that TCD machine is sitting on our pump and not behind the anesthesia curtain.
Right. Well, that's
what I
Right.
think we
I
should
mean,
do.
yeah.
That's the idea.
Or make it where everybody sees it.
Right.
Not just.
Yeah,
not
you
just,
can only see, you can see it
Right.
and hear it.
Yeah.
So, they have them so you can hear them as
Surgeon
well.
and
Oh,
anesthesiologist.
that would be
Bob Groom, that was his name. Bob
Yes,
Groom. I
Bob
told you I'd
Groom.
eventually think of it. Bob Groom. I used to think Bob was just full of it.
Oh.
That Bob, I thought you were wrong.
Yeah.
If you're watching, I just
Yeah.
thought you were
Yeah.
wrong. You were crazy. You wanted us to do all this craziness. Who cares if there's air? Whatever. But then years later, I realized he was right. And he was doing this in the 90s. But it
TCD?
didn't- Yeah, TCD in the 90s. He wrote some great articles that you could find. Really, really, really good. And he's 100% correct. So anyway, with that said, what about, we talked about angiovac, we talked about TCD. What's your feelings about CVVH? What's your feelings about whether or not that one particular item, but just in general, adopting or trying to draw into our toolbox a lot of these different tools?
Right.
No, I asked you.
Oh, okay. You asked me. No, I think we do need to draw in on the toolbox. CVVH is something that we need. These guys are getting overloaded. I mean, these people are getting volume overloaded, and people think that, hey, we need this volume on board to, for their hearts, but it's going in the lungs, and it's just causing this multi-organ system failure along the way. So if we have a device that will take that volume off at a reasonable rate, I'm not talking about like a huge rapid rate or anything like that. If you do it in a responsible way, I think it's very effective. Like anything.
You can't remove your plasma refill rate.
Right.
You have to have volume to get volume.
People have to
off.
understand. Some of these physicians and the nephrologists really have to realize that too. I mean, there's a lot of nephrologists in a lot of our hospitals that don't care for the CVVH and CRRT and that type of thing.
I don't understand why.
Well, I don't understand why either, because at the other hospitals, it's very effective. I mean, it's not just us using it; it's the RNs, and it's a great tool.
We almost had a case today, you and me. Well, you mostly.
Me mostly, but yeah, you would have started it.
That the patient came into the cath lab, they couldn't get stents in where they wanted, they needed surgery, but they were also in renal failure, they had a very high potassium, and the hospital did not have CVVH, and the surgeon knew that we were going to need that, and so they decided to transfer the patient out for that reason. So that's how important it is to some
makes,
people.
I think that made a lot of sense.
Yeah.
You know, dialysis, though it's been around since the 50s. I mean, it hadn't changed much since then. It's still kind of the same thing that it was back then. But you're getting very rapid. You know, you do dialysis, standard intermittent dialysis, in usually a 4, maybe 6 hour spread, and you're creating very large acute electrolyte shifts and fluid shifts in a compressed period of time. So hemodynamic instability is not uncommon when using intermittent dialysis. And when you have a patient who is already hemodynamically unstable, that's really hard to do. And I think CVVH, being that it is continuous, it runs 24 hours at a time, much in the same way the kidney does, and uses convection versus just diffusion for the removal of unwanted evil humors floating around in the plasma water, that you remove much larger molecules. So the inflammatory mediators that you cannot remove with standard intermittent dialysis because it can't get across the membrane with only diffusion pressure. It can do it with convective pressure, but it can't do it with or gradients. It can't do it with just a diffusion gradient. So another person called and asked, or on the evaluations, asked about TAVRs. Now we don't do TAVRs, but what they wanted to know is, what can go wrong? How do you prepare for doing TAVRs?
That's like a perfusion.
Have you done TAVRs?
Have I put a patient on pump from a TAVR problem?
Yeah.
No, because I believe there may not be time. I mean, what would you do?
I would need to hear this.
Yeah, I want to hear this too.
So
in case
I guess
you're watching,
we'll
talk. But we're going to do a program on this. You know what? I need people to give me some feedback about what they want to hear about, and get involved. If you've got the experience, call me. Okay.
Yeah.
Email me. Send me snail mail, email, whatever. Do something. Okay.
So, back where I used to work, we actually mandated the fact that our hybrid room would be in the OR, and which made a lot of sense. You had a surgeon in the room because that was their domain versus the cath lab, because what does a surgeon do in the cath lab but sit there behind the glass and wait for that case to come up and ask where are my targets. So you get in the realm of the OR, and you have all the sterile products, you have all your sterile tables and back tables, and you just set it up just like a cath lab, but with an OR table. You got your C-arm, all your monitors that all the cardiologists are familiar with, and and then you get your surgeon in there who is familiar with just the operating table and just his regular screen. So I have sat there and watched TAVRs, and we were doing the Medtronic and the Edwards, and these are very old patients. These patients have very friable aortas and things like that. And it's very, very likely you can occlude your coronary arteries.
Especially
the osteo, the at
with
the
Medtronic one.
Yes,
because isn't that a supraannular? I think it is, but whatever. It doesn't matter.
Right. Nonetheless, I mean, you always have that. You always have that risk. You're watching this valve that's literally on a stick, and it gets expanded within the aorta. You're just watching that radioscopically. I mean, just over a television screen versus the surgeon opening up your aorta and directly visualizing and cleaning out the annulus. But nonetheless, I did crash on bypass. I had the crash on bypass.
What was the reason?
What
happened?
Because we occluded the right coronary.
Okay.
And there was
big problem.
Yes, there was a huge problem. We were sitting there and we're like, oh my God, we have to take vein, but we were right there. That patient was draped sterilely. Everything was done in the conventional way, as if it was an AVR. Cath lab moved out with their back table, their sterile back table, which, believe it or not, if you've ever been in a cath lab, isn't always a sterile back table in the cath lab.
Right.
But, our RNs from the cardiac suites would, take care of those tables. So we moved that cath lab table out, moved our standard AVR table in, and we were on bypass within 2 minutes. Within
your
2
pump
minutes.
was
Our
set
pump
up
was
and
set
primed?
up. It was set up, not primed.
Not primed.
But we were, we were waiting for cannulation, so we have that time for cannulation. The nurses are setting up, the vein cameras, the endoscopic stuff, all the towers. But yeah, we could be on bypass in 2 minutes.
Okay,
I mean, it was
that's
fast.
pretty good.
I'd like to mention something though. The thing about TAVRs, and this is, a TAVR patient is a TAVR patient because they're a non-operative candidate. They're a non-surgical candidate.
They
That's
used
why
to
they're
be.
getting that.
They used to
Oh,
be.
they changed that?
Now, yes.
Okay.
Yes.
And that's why I didn't know they changed
Yes.
that. So I'm like,
Yeah.
why are we standing by for somebody we're not supposed to operate on?
Right. Yeah, that's actually a good question. It's very much like that. I mean, it's almost where the cardiologist looked at the perfusionist like, well, why are you here? We had another hospital within that same system where we were an afterthought. We're like, oh, we can do this without cardiac surgery, and that includes the perfusionist, right? Mm-hmm. So that hybrid was actually built in the cath lab. So it didn't have the same standards as a regular OR would, such as an open sink. An open sink. And if that may not mean anything to anybody, but if that sink backs up, or a rodent comes up through those pipes,
Yeah.
congratulations, you've just
they probably don't have the same back pressure that operating rooms.
That's correct. That is correct. They have a different standard. So if people think of it, a lot of people don't think about that.
Mm-hmm.
Yeah.
Mm-hmm.
Or
that's a good point. But there was recently. So this is where I'm trying to go with this. Yes or no opinion. Do you think that any time a TAVR is done, there should be a heart-lung machine in the room, primed, ready to go on bypass?
That's a good question. Not primed. Not primed. I think if you get a seasoned enough perfusionist or a perfusionist that's worth their salt, they can get on bypass. They can prime and get on bypass because you're not setting up cardioplegia right away. You just get them on.
Right. Yeah.
You get them on. You get them through the crisis, and then you can get your cardioplegia going.
Well, I would say yes. We're not doing that now here, but we are in the room.
I'm so sorry. I just can't hear you. You good? Okay.
So, if we are going to be standing by, we're standing by because we're potentially going to go on bypass. That's why we're here or there. So I would say, yes, but it isn't what we're doing. And, you do get those looks sometimes from cardiology, and they're like,
Right.
What are you guys doing here?
Right.
So there was a case just recently. You both are familiar with it. It was a nephrectomy. Patient had renal cell carcinoma.
Right.
They get in there. There's no pump. The pump's not set up. The pump's not primed. The inferior vena cava starts to fall apart because the tumor was invading it. Next thing you know, tumor breaks off, goes into the pulmonary artery, causes a big pulmonary embolus, and there's a mad scramble to put that patient on bypass. I mean, the heart-lung machine, for all that it can do, is a relatively, in the overall cost of a procedure,
Right.
minimal.
Right.
Minimal.
Right.
Why worry about what, $600, $800, $1,000 tops when you're spending $28,000, $30,000 on a valve?
No, I agree
Seriously.
with that. I agree with that. But
I would love to know y'all's opinion too. You can chat that on here and tell me if you think I'm wrong about that. If you're perfusionist and aware of that.
So with that,
anybody.
So with that perfusionist, we don't just show up. We also show up with our cardiac nurses. We also show up with our cardiac surgeon. So there's an entourage that comes with this. So maybe it confuses that surgeon or say cardiologist and it gives them that that feeling, hey, you know what, this is my case, you know, this is my territory, what are you guys doing here kind of deal. So it becomes a territorial thing, and
sure,
at one hospital it really felt like that, only
sure,
because we were an afterthought, and it's like, hey, well, there's really not a surgeon here, but I'm here, so what am I doing here without a surgeon, because I'm not able to cannulate.
Right.
Mm-hmm. Yeah, I mean, exactly. I mean, you're exactly right. I don't know. Joe Vadrine, I asked him, I hope he could call in. I think I'd love to be talking to somebody instead of doing this chat thing. I think we might even take this chat away because I don't really like it.
Right.
Okay, I'm having to pay attention
Yeah.
to this. It's sort of frustrating for me, but maybe it's just my lack of experience with it. I think that might be the issue. But, you know, he says that they use a primed pump for these cases, a primed pump.
So for TAVRs, are we talking
For
TAVRs or
yeah,
okay?
For TAVRs.
And I wonder
So-
if they're in the room or if they're just have the prime pump.
No, that's why I
in
asked him to
another
call.
heart
I
room or
don't know. That's why I
Yeah.
asked him to call in.
Yeah.
That's a good question. But if you have a prime, you know, my thought is yes, a good perfusionist, even a okay perfusionist,
Right.
can prime a pump quick.
Right.
Okay, but what is more likely? When is the time more likely for no matter how good a perfusionist you are or think you are, is it more likely that a mistake can be made
Oh, absolutely.
during a crisis and you're
Right.
trying to prime it, or it's already primed and you just hand
Sure.
the lines up?
Yeah, that always enters your
That
mind.
always
When
enters
you're
your
going
mind.
fast and you know
Right.
that's
Yeah.
the highest risk.
That's
you know.
when mistakes happen.
Yeah.
They happen all the time.
Yeah.
And I think that, you know, I just don't know how we ended up being such an afterthought and not involved in saying, look, this needs to be in the room, primed and ready to go.
Yeah.
And you know what? You're just going to eat the cost.
Yeah.
It's not that much.
Again, I think it's a territory thing, and it depends on where that hybrid suite is built. Honestly, you know, it's you know, it really has to be a collaborative effort because it really is. You know, you can't have a cath lab program without surgical backup. At least you shouldn't. At least you shouldn't. And a lot of these nurses, going through this career, like, oh wait, who's the surgeon on call? Whether
But
everything
now
was
TAVR
going
has
well.
to be done to be paid for it. The cardiologist
Yes, they have
can
to
do it.
That's correct. Go ahead.
But you don't get paid.
Right.
You have to have both a cardiologist and
Yes.
a cardiac surgeon.
That's correct.
In the case.
Oh, yeah.
In order to be paid for it.
Yes.
Right, but you're only paid as if you were paid for an open AVR, which is, you know, somewhere for the DRG for that's probably, I don't know, maybe 25, 30,000 maybe somewhere around there.
So how do
Hardly
they-
the cost of the valve,
Right.
Right.
you know, or barely the cost of the valve itself. So, you know, something to be, to think about there. Okay, so why don't we do this? Everybody, I'm getting ready to, we're gonna take a short break. I'm losing my voice. We try and make as small a footprint as possible.
Right.
Hold on, Joe, let me say this. Joe, I love you. Please call so I don't have to keep typing and reading.
Is everyone afraid of their voice?
Yes, and I'm losing mine.
Please call in.
you do
Please
call
call
in,
in.
Something
Yes.
you didn't
Go ahead.
mention is if
I'm sorry.
if anybody calls in, we're on a 20-second delay, so you have to
Yes.
turn your computer off or whatever.
Yes,
Turn
yes.
off.
turn it
that's
down.
absolutely
Turn it
right.
down.
And you know what? If you call in, Patrick is going to give you his prize. You win his prize
Yes.
for Employee of the Quarter. Look, I need to get something to drink.
It's
I'm
a
losing
pretty
my
cool
voice.
prize.
So let's go to
Yes.
commercial, please. Show a couple of words from our sponsors and give me my voice a break here.
Imagine trying to drive a car looking only through the rear-view mirror. Critical decisions would be based on old and possibly inaccurate information. The same can be true of performing cardiopulmonary bypass without continuous inline blood gas monitoring. Terumo's CDI Blood Parameter Monitoring System 500 continuously delivers 11 critical blood parameters throughout the procedure. With other systems, periodic blood gas measurements provide static information. That is helpful, but limited. Continuous monitoring tells you what you need to know every step of the way, and that reduces risk. Studies show a direct correlation between blood gas management and reduced complication rates. The CDI System 500 has been earning the trust of cardiac hospitals and cardiovascular surgical teams for almost 20 years. It provides continuous monitoring of 11 of the most critical blood gas parameters, utilizing industry-leading technology. During cardiopulmonary bypass surgery, the shunt sensor can be placed in any arterial or venous shunt, or purge line with continuous flow. The shunt sensor uses optical fluorescence technology to measure PO2, PCO2, pH, and potassium in the blood. 4 microsensors and a thermistor well are in direct contact with the blood to accurately and rapidly measure the values. Light-emitting diodes direct light pulses toward the microsensors, which contain fluorescent dyes. The intensity of the fluorescent light from the microsensors will vary depending on the levels of PO2, PCO2, pH, and potassium in the blood. The photodetector measures and converts the light to numerical data, which is then displayed on the monitor. Blood values are always current with virtually no gaps. There is no need to make difficult judgments about when to draw a sample. Gas source or oxygenator failure can be rapidly detected. Continuous monitoring is especially beneficial during procedures on young or old patients, or with smaller perfusion circuits. Peer-reviewed clinical evidence supports the value of continuous blood gas monitoring. Contact your Terumo sales representative for a demonstration, or visit terumo-cvs.com.
And welcome back to the program, everyone. In the last 20 minutes that we have on the show, I've decided I was going to call Joe Vadrine. He keeps texting chat things on here, but he says, we're always in the room. We use a... Joe, is that you?
Yeah.
Yep, I'm calling him, yeah.
Did Joe plug it?
No. Joe, no, it's just real low. I can hear him. Joe?
Hello?
Joe.
Oh, there he is.
Yeah. Joe, okay, so let's talk about your experience. How many TAVRs are you guys doing?
Oh, we do a lot of TAVRs. We do, I don't know, probably 60 a year, something like that.
Wow, that's
60?
Wow.
Yeah,
Wow.
that's quite a bit.
Now, what has that done? Now, are you doing only high risk? Are you doing medium risk? Or are you doing low risk?
I'm sorry, what was the question? Are we doing high-risk TAVR?
Yeah, on the TAVR patients, are they patients who are not suitable for surgery, or are you doing, low and medium risk patients?
We do a lot of TAVRs. We do a whole bunch.
No, but what I'm trying to say, Joe, is are you doing them only on patients who are too sick to operate on?
I have to put my sound down. Hold on.
Yes, you have to turn your sound. No, I see.
Yep. Turn.
Yeah.
Yep.
Yeah, you have to turn your sound down because
There
there's
you
a
go.
delay.
There you go.
Are you doing TAVRs on only high risk, those patients who are poor candidates for surgery, or are you doing low and medium risk patients as well?
Yeah, we do not just high-risk patients, but we talk to the patient and we determine. Usually we do 3 or 4 when we do them in a day, and we determine whether they're going to be open or no open. That's what we classify them as. If they're no open, then we don't have a pump. because we're not going to take measures to put them on bypass.
Okay.
Because they're too sick.
Okay.
Okay.
But we have some that are, we determined that are open, and those we do have a prime pump in the room.
So if you're going to do anything more to rescue the patient, should something not go well, you have a primed pump in the room.
Yeah.
Now, it does...
And we've gone on bypass like 3 times.
Really?
Since we've been doing TAVRs.
Yeah.
Really?
We were, yeah.
What was the primary reason, or was there a similar reason or different reasons for all 3?
No, it was 3 different scenarios. You know, the biggest danger for the patient is when they balloon. You know, they inflate the balloon and they put the pacemaker on like 180 to lower the cardiac output. And sometimes they won't come back. You know, they won't come, the heart won't come back. And
wow.
So we have to crash on bypass. So that one time we punctured, this is just right at the beginning of the case, we punctured the heart with a wire.
Wow.
And so we had to crash on bypass for that. And then one time it was a redo, it was a post-cabbage, and we cut the heart. And so the patient is hanging.
Oh, that's problematic. So
yes.
Of the 3 you put on pump, what was your survival rate to discharge? Not just out of the cath lab, but actually, or out of the hybrid room, but where they left the hospital alive?
1 out of 3.
1 out of 3?
Right.
1 out of 3.
Yeah.
Wow.
So I have a question, Joe. Where is your hybrid lab? Is it in the cath lab or is it in the OR? Okay.
It's in the OR, yeah.
Yeah. So
wow.
it's that's interesting. That's interesting.
That is. So what has it done to your just surgical, your SAVR volume, your surgical AVR volume?
Yeah.
Do you even see a surgical AVR anymore?
Infrequently.
Wow. So it's taken. So this TAVR program has taken away from your conventional AVRs.
Oh God, yes.
Oh really? Yeah.
Right, and there's what 35,000
right
AVRs done in the country a year, so that volume's going to be potentially dry up. You know, I'm curious because you do so many more of them than I do. You know, the people that do them, you know, like the folks down in the med center, you know, that are doing them, they're very, very, very supportive of it. They're really very, almost, I don't want to use a word let me think of how I want to say this. They're believers.
Yeah.
I'll put it that way.
Okay. Yeah.
And they think that this is going to be how it's done. I'm not so convinced. I'm not so convinced that TAVR will truly endure. You know, I remember, Joe, you may remember this too. Do you remember, does anybody here remember port access?
Yes.
Okay, or heart, it was heart port. Now
Heart
it's
port.
port access.
Correct.
But if you remember heart port in its original iteration,
yes.
How that was supposed to be how we did all heart surgery. And that ended up a disaster. But everybody believed in it. Everybody invested huge amounts of money. Everybody lost huge amounts of money. And it's been reintroduced not too terribly long ago as port access. But it has the same problems. It's the same device. And I don't think it makes any sense. But everybody really believed in it. I know they're investing huge amounts of money in this, and I know people who are very, very smart, and I have a lot of respect for their opinions, believe that there will only ever be TAVRs done. But, Joe, I'm curious what you think, and I'm curious what you think. I don't think so.
Well, I believe the studies show that they're very efficacious and effective. You know, there's no long-term studies yet because it hasn't been doing that long. Mm-hmm. But they're leaning toward going, you know, to TAVRs, you know, exclusively almost. Mm-hmm. That's what the literature suggests.
Mm-hmm. Mm-hmm. See, I, you know, again, I'm biased, I hope it's a tool in the toolbox. I get it. I mean, like off pumps. This is AVR's version of an off pump. Mm-hmm. So I see it.
It's a good analogy. I like that.
I see it as a tool in the box. It's not for everybody. I mean, if it were me that needed an AVR and I had a bicuspid, aortic valve, I'm definitely gonna want a zipper. I want an open chest. I mean, this surgeon is going to look at my annulus, size it out, and if there's calcium around it, clean it up, get it done, in and out. Mm-hmm. So that's my feeling.
My chest cut.
Yeah.
You don't?
I could go in the groin and put one. No.
Yeah. Really?
I'm with you, Joe. I mean, if it's really consider, I don't know what. There's probably statistics out there about how effective or what the complications are in compared between open chest and TAVR. There's probably a difference in that, and my guess would be there are probably more complications with open chest, post-operative complications.
I mean, I think you do. I disagree with both of you. I'm on Rodell's side on this. I think that the morbidity and mortality associated with isolated surgical AVR is remarkably low. And then, how do you reconcile that 100%, not 90, not 80, not 99, 100% of patients who have TAVR have a class 2 stroke? So we all know stroke is, what we're used to seeing. They have a hemiplegia. They dribble their soup out of their mouth. They can't talk. They're blind in one eye. Whatever. The obvious overt stroke. But class 2 strokes is any new lesion in the brain with diffusion-weighted DWI, diffusion-weighted MRI. And so we know, latest studies just recently done, that show that there is 100% of patients receiving TAVR have new lesions on their MRI in their brain. And these lesions are not benign.
When do you think that's happening? At the
I think it happens during everything. Just putting just putting the catheter.
Putting the catheter in.
Well, now that's true. I think that's what needs to be studied.
Yeah.
Is which has more, which is worse, and what is the long-term sequelae associated with these new lesions that occur. And that's a very fair and valid point.
Yeah.
But you can't sit here and tell me that taking a catheter, a balloon, and shoving it through the aortic valve, turning on a pacemaker at 200 to speed it up and lower the pressure, inflating that balloon and crushing the valve and the calcium and the annulus and everything else, and then deflating it, and then pulling that out, and then ramming up a 22 French catheter. It's not just some little guide wire with a valve on it, scraping it along the superior surface of the aorta or through the arch. Every time it goes, bang, 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 there's more gradu. Gradu is a Louisiana medical term for atheroma.
I've heard the term.
And you know that.
I've heard the term.
You knew what gradu was, Joe. The gradu goes showering up there, and then you implant the valve, more showers. So, we don't look at it, and we need to look at it. Somebody needs to look at it.
Sometimes the fields can be implemented downstream.
Well, they do have. I mean, there is a new industry that is cerebral embolic protection devices.
We've used it before.
Okay, but even those can create, believe it or not, those themselves can be responsible for emboli that was unintended. So nothing is benign, and it's not. In my view, it's just not that simple as everyone wants to make it out to be. I don't really. I'm 61. If I needed an isolated aortic valve right now, I would go to somebody that does them, knows how to do them, and I would have it done open. I wouldn't have a TAVR. I just wouldn't have it.
Well, there's still arguments going on about off-pump cabbage compared to on-pump cabbages. Which one is better?
Well, again,
some surgeons are convinced that on-pump cabbage is better.
But it is.
They are, yeah.
On my chest split, if I didn't have to go on pump.
Yeah, well, I'll and I differ with that. I think that's what I would look at your chat. Hold on. That's I differ with you on that. I would rather have the open. I know they're going to clean the annulus up. I know they're going to get a good size. I know they're going to, it's going to be they're going to clean everything up and then close me up and take me off pump. I think for me, that's the way. It's just the way I would do it right now. At my age, it is the way I would do it. Now, if I was 85 years old and had emphysema and was somewhat debilitated and probably was never going to get off the ventilator, I would have a different viewpoint of it. But I think that I would take my chances on opening up. And I'll tell you what, too, it brings up the issue of what are we doing in terms of what's going to happen when surgeons can't put an aortic valve in. When they can't it open, when we do TAVRs and that's all we do, and the surgeons can't do it and then they're not trained to do it, and then it turns out that, TAVR at 10 years has a much higher failure rate than did a regular, I'm 61, I'm getting a mechanical valve. It's going to last me forever in the aortic position. I'm never going to have to do anything. So, and take aspirin and Plavix and I'll be done with it or whatever. I'll use whatever valve. But, if you have this done, it's a tissue valve for certain, so it has the potential to basically calcify, early calcification and degeneration of the leaflets. And then what do? You go put a valve, you put a valve and a valve, right? You do the valve, you do the in-stent stent. This sounds to me like it's stenting. And the off-pump, on-pump thing, let me tell you what I think about that. At one time, we were at 28%. 28% of all cabbages were done off pump. Do you know what percent of cabbages were done off pump last year? Anybody want to take a guess?
I'm guessing 5%.
A little higher than that.
Really?
10?
10? What do you say, Joe?
25.
Nope, 11.
11%, yeah.
11% down.
Well,
it was all based on one paper, too.
And it's going to continue to go down.
It's based on what?
It was one paper, I think, that came out.
Huge paper.
It was a huge paper, though.
It was in New England Jam or New England Journal. One of the
New England Journal.
Huge.
Yeah.
So
and we did have the same kind of thoughts about stents as well, coronary stents. When they started getting bigger and it was like, the whole going on pump thing is going to go away. But that didn't happen either. So.
Okay, Stephanie asks, she makes a comment, many TAVRs end up with permanent pacemakers. And I do think that's very true. What's your experience with that?
Well, I think Edwards' selling point is that they have less pacemakers as opposed to other brands of TAVRs.
Less, but not none, right? Less. But I think it's still more than SAVR. It's more than open, I think. I'm not sure. But,
I don't know. That's a good question. I did the follow-ups on a lot of like SAVR patients and TAVR patients. I mean, you are messing with right coronaries and things like that, and you're just moving things around. A lot of my AVRs also had cardioablations along with them. So they would mess with the conduction system as well. So maybe they would get a temporary one. Maybe possibly down the road they would get a pacemaker. So it was, maybe half of my SAVRs. So, I just followed up on that because I followed them from, all the way to discharge. So I would see what types of interventions they got, and half of them did get pacemakers.
Well, Joe, let me ask you this one last question. How's the crawfish right now at home?
I've been having all these for crawfish.
Huh?
I haven't had them yet.
You haven't had no crawfish yet this year?
Not yet.
He's got the Envy. Okay, if anybody out there knows what the Envys is, if you can tell me right now, text it right now, you will win a prize. Patrick is going to give away his prize that he won for being the employee of the quarter. But listen, man, why don't you come visit me, or I'll come down. We'll come down and I'll cook you some.
Sounds good to me.
All right, that sounds good. Joe, thanks very much. We're gonna
thank you.
We're gonna wrap up. This
Thank
was
you.
a great discussion. We sort of got focused in on TAVR and SAVR, but that's good because we actually had that on one of our evaluations, and I think that person is in fact watching right now.
Perfect.
And got some good information from somebody who has a lot of experience, a whole lot more experience than I do, or any of us really, on that. Well, current experience. I have very little experience with TAVR. I mean, I've seen one as an observer.
Yes.
That's all I've done. I have no other experience with it. Do you?
I've seen a couple, honestly, since we are not really, it's happening in the cath lab. If I'm covering one, I really don't go there. I mean, I pop in and see if they're done.
Are you kidding?
That's what you're supposed to do.
We're supposed to have a pump in the room.
Well, that's what we think we should do. But if we were to roll a pump into the cath lab where they're doing this, they'd be.
We don't have any connections.
Yeah, I don't even think we could. What we were suggesting is that we should do this in a hybrid room.
In the cath lab, before we got the hybrid room.
You did roll a pump in?
Okay.
Yeah, we just remained anonymous in the corner.
Yeah.
Right.
Just tried to stay out the way. We did ACTs for them.
Yeah.
And occasionally a cell saver, but usually just we stayed in the back and just did ACTs and called out the ACT value. And when they first started, all of them were study cases at first,
Yeah.
So they had very strict criteria that you had to follow, and one of them was you better do the ACT at 30 minutes exactly.
Really?
So
Okay. That was part of the study.
Yeah.
Right, exactly. That concerns me.
You didn't know that we don't. Well, we don't have a
station.
I didn't know we were doing that.
We're in-house. You don't.
I didn't know we were doing TAVRs in any of our hospitals.
I won't mention the one, but yes,
Yeah,
we
please
get
don't
called.
do that.
Please don't do that.
We get called for standby sometimes for TAVR. And
Okay, so Joe, of the times you had to crash on pump, if you had not been in the room with a pump, primed and ready to go, would that patient have survived?
Well, obviously two of them wouldn't have, because they didn't make it with a pump in the room.
That's true too, but the one that did, the one that survived.
I think so, because that was the one with the puncture part, camping out of it.
Oh, okay.
I mean,
All right.
so what we're saying is we gave them a better chance at survival with a primed pump, which is something we have to do. Sometimes it just happens to be a salvage.
That's a discussion. I think that's a discussion.
Sometimes it's just
we
a
need to be
salvage.
having with somebody.
Sometimes it's salvage. I mean.
Yeah.
did your patient survive?
Now he did mention.
Yes.
Joe did mention that if the patient is you said non-open, meaning if something goes wrong, we're not going to open. Well,
well, they might do an impella on them or a balloon pump,
Right.
but they would not put them on cardiopulmonary bypass.
Right. In that case, I don't even think we should be in the room. I mean, we don't need to be in the room. If that's what the decision's already made, I mean, that doesn't make sense.
Hey, another quick question, Joe. Are you involved with inputting the impella?
The hospital does the impella, but cath lab handles it.
Okay.
Who monitors? How many ECMOs you doing?
We don't do any ECMOs. We've had one ECMO ever.
So then the impella, who monitors the impella? The nurses in the ICU?
Yeah.
Okay.
Yeah.
All right. Well,
thank you, Joe.
Thanks,
Thank you
once again, thanks for answering your phone. You wouldn't call. Were you able to read my text saying to call me, or did you just not see it?
No, I read it.
Thanks.
Well, alrighty.
I was kind of paranoid about calling and
Don't please don't.
everybody hearing my voice. But I didn't know if it I called, if it was going to be a text call or a voice call. So I was confused. So I kept typing on the internet.
Yeah.
Okay, well that's good. Well, I'm glad I called you, and I'm glad Joe answered your phone. It was a great conversation, and we appreciate very much your perspective and experience and sharing that with everybody. Thank you.
Yeah.
All right.
By the way, our surgeons are involved in every TAVR. They help in place the guide wires and all.
Yeah.
And so they're involved with every one of them.
That sounds good.
Yeah.
Okay.
Thank you.
Thank you again, Joe. Take it easy. Good night, and let's get together and have some good crawfish.
10-4.
All right, buddy. Bye.
Have a good night.
Bye.
Bye-bye.
So we're going to wrap up. I just can't thank everybody enough. I think this was a very lively, provocative conversation about some really tough subjects. I hope everybody, got something out of the presentation that I did originally, and that I made some good points. It was intended to make people feel a little uncomfortable about what we're doing and how we should be involved. But I hope that it has a positive effect. That's what I at least hope for. I am in the process of getting the next round of webinars set up. Now, I will tell you that we're trying to figure this out. We're trying to do this at convenient times, after hours, Saturday mornings. I do put on the evaluations what times work for you. Some people have said this time works great. Some people have said Saturday mornings is fine. But I'm trying to figure out, is there a way to do this as a program that goes Friday evening, Saturday morning with 10 CEUs, so that we can maybe increase the number of CEUs, do 4 hours and 4 hours, or however it plays that itself out, in order to achieve 10 CEUs, or even do a Tuesday or a Wednesday and a Thursday. I'm not sure, but I'm going to put it on the evaluation. I would really appreciate you guys' opinion on that. But please be looking for it, because I'm going to be, like I said, sending in the next round of applications to the ABCP and getting them scheduled. So I'd love the feedback so that I know kind of what direction to go. We will figure it out, what's going to be best for everyone, but your ideas, of course, are going to make this a whole lot easier for me to do.
Yeah,
and,
absolutely. Tell your friends. Tell your friends.
Tell your friends. That's right. Tell your friends. Cajole your friends.
Yeah.
Tell your friends if they watch, they get Patrick's prize.
Yeah.
That's always number one. And that's very generous of you to give that like that. I appreciate it a lot. But yes, tell your friends about PerfWeb and how we do things here and how this is working. And that's about it. I want to thank this very esteemed, capable panel. Thank you guys so much. I want to thank everybody that's running the cameras, Austin and David and Vicky. I want to thank Roger for his hard work over there at keeping the stream going and distressing when the internet speeds fluctuates and all that kind of stuff, and switching camera angles. He's got a heck of a job over there, but a really impressive looking command center. Looking forward to seeing you all next time. Thank you very much, and good night.